All right. So, again, thanks for joining us tonight for the March Journal Club. As always, we want to thank our sponsors, including our title sponsors, ATI and IMISCA. We have Enrique joining us as a resident from ATI to do the case in point at the end of our Journal Club tonight. So make sure you guys stick around for that. Our founding sponsors, Innovus Woodway and Hyperice, our platinum sponsor, Elevation, of course, also our gold sponsors and all of our partners that make the IJSPT possible. Couple of reminders, we do post these into podcast format afterwards, as well as onto our YouTube and our website. So feel free to rewatch or share with your friends. You are only able to get CEUs for live attendance, participating for more than 35 minutes. Those certificates get sent out from a third party within about 24 hours of the end of the webinar. I will actually send the links to the papers for anyone that didn't have a chance to look at them in the chat after we get started. Both of them were published in a couple of different journals, including the IJSPT. So I'll send the links to that directly in the chat. Use the Q&A feature throughout Journal Club tonight if you have any questions, and we'll be monitoring that. And then lastly, unfortunately, I was tasked with just taking a quick moment. Hopefully, those of you that are on our listserv have seen the email that went out. If you hadn't heard that we lost a member of our sports PT community less than a week ago, last Thursday, our friend and colleague Russ Payne passed away. We have a very nice tribute written by several of his friends in the community in our email, and that will go out in the April issue. So please be sure to check that out. And we just want to take a moment to thank Russ for everything he's done for us, not only professionally, but more importantly, as our friend. So, as we always do at Journal Club, we do tend to have our drinks off to the side, but tonight I'm going to officially raise my red wine to Russ in his memory and thank him for everything. So, without further ado, he would want us to continue on
Press.
and continue learning and growing together as professionals. So I'm going to turn it over to Rob to get us started on tonight's Journal Club.
All right. Thank you, Ashley. Yeah, that's a kind of a somber note to start, but you're 100% right. Russ would want us to carry on. Russ would love this topic. You know, he was a knee physical therapist, knee and shoulder
Yep.
physical therapist. I remember hearing him teach me and a lot of us about knee injuries and meniscal injuries at sports, the old TCC back when we used to have it. So
Yep.
he would definitely want us to continue. And I know he's watching us right now, happy that we're doing this talk tonight. So here's to Russ. Um, we got a great talk tonight, everybody. I'm going to get to our guest in just one moment, but we have several other people that I want to introduce. I didn't even introduce myself. I'm Rob Manske from Wichita State University and Ascension Via Christi. Mark, can you introduce yourself real quick?
Yeah, good evening. I'm Mark Paterno. I'm at Cincinnati Children's Hospital in Cincinnati, Ohio.
Great. Barbara?
Hi, I'm Barb Hoogenboom. I'm the editor-in-chief of IJSPT. I hail from Grand Rapids, Michigan, recently retired from Grand Valley State, and I'm camping out in Cleveland right now.
And Phil?
Bill Page, professor at Fran U DPT School. Just happy to be here, and thank you, Ashley and IJSPT and all of our sponsors and our guests for being here. I appreciate it. And Rob for always doing this. What is this, like 52 or something?
No. It's close. You're close though. 47. 47. We're getting close to the 50 mark, believe it or not. Yeah.
Yeah, some of us are
Yeah.
getting closer to like 60. So
Thank you.
47.
47. We're going to hit the 50 before long.
Yep.
But yeah, thanks, Phil. So everybody, our we have a fantastic guest tonight. Our guest is Dr. Benjamin Ma. He's an orthopedic surgeon who specializes in sports medicine, arthroscopic shoulder surgeries, ligament instability, shoulder replacement, knee ligament reconstruction, meniscus, cartilage, and all things sports medicine, which is why we've asked him to join us tonight. He wanted to talk. We guys, I don't know. We don't usually tell everybody this, but we ask the guest what kind of topic they would like to talk about, and Dr. Ma is gracious enough to pick one that he helped with, but so did Mark Paterno and I, and several others from the Academy. Jay Eargang, Jill Monson, Laura Schmidt, and Ariel Giordano all helped with this consensus statement. So thank you, Dr. Ma, for joining us tonight and picking this article. I think it's going to be a great one to talk about.
Well, thank you. Thanks for inviting me tonight. I'm looking forward to chatting with you all. I did not get the memo, Ashley. I did not get the memo that I need to get a glass of wine for the journal club. So I'm kind of stuck with my little, tea over here. So if I'm ever inappropriate right now, that's because I don't have the right kind of a
That's
Beverage.
Rob's
beverage,
fault. He's in
tonight.
charge
So
of the
yeah,
guests.
Yeah.
apologize for that.
Sorry, Dr. Ma, that's my fault. We're going to get you on again, and I will definitely notify you ahead of time. You can have a beverage. All right, so everybody, our only, we're only going to do one tonight. I think we're going to have enough conversation with this one. It'll take us the entire time, but it was published in several journals. I guess the one we printed off was from Knee Surgery, Sports Traumatology, and Arthroscopy, but the title is The Formal EU-US Meniscal Rehab 2024 Consensus, an ESCA AOSSM AASPT initiative. This is a second part, part two, prevention, non-operative treatment, and return to sport related to meniscus. So first thing I want to say is that, Ben, we had so many people helping out with this. There was a lot of people that helped put this together that we really need to thank. An incredible, huge group of surgeons, huge group of PTs, and I just want to say kudos to you because you were one of the main drivers of this. I mean, I remember doing the getting on Zoom late at night, some nights to go over all of the findings we were finding and try to synthesize all this information. And I just want to thank you to begin with because I think that this speaks really highly of your leadership skills, your organizational skills to be able to put all this together. Would you like to say anything about, it had to be difficult and hard to do this, but you obviously did it very graciously.
No, thank you. And I can't take all the credit. This is really about the whole team and also our staff that really kind of make this happen. This is the first time that we've done this. So ESCA is the European Sports Surgery, Knee and Arthroscopy Association. It's kind of their, kind of a society for sports medicine. And also they do have a, orthopedic surgery and physical therapy within ESCA as a society. And obviously, AASPT is, your society in terms of, sports physical therapy. And AOSSM is kind of where my, role was when I was leading this effort, which is American Orthopedic Society for Sports Medicine. So this is the first time that the three society came together to work on consensus statement. ESCA has been working on this for quite some time. I think Philippe, before I've been working on the consensus statement with the ESCA Society for probably about 6 or 7 years. They actually every few years look at kind of sports related injuries or condition. They want to kind of generate some type of consensus so that the members could kind of refer to. But this is the first time they kind of included the American colleagues or North American colleagues and us to do it. But yeah, it was I would say, I don't know, Rob, Mark, it's fun to look at things when it's done, but when we're doing it, it's a little bit stressful, a little bit hard to get it going. And I still remember the first time we had the kickoff meeting, we had like, what did we sign ourselves up for over here? But it was very exciting that we actually have two really great consensus statement that came out to kind of share with the community about what the evidence is in terms of rehab, following meniscus injury. So hopefully this contribute and add to the knowledge we have about this issue. Yeah.
What do you think? Can you explain to us what you think the significance of including, say like a physical therapist and or different countries? What's the significance of that? How do you feel that makes this statement better?
It obviously, be more generalizable in terms of what the findings were. I think it's clear, especially with this topic about rehabilitation, that we need to include our physical therapy colleagues like you all to be part of this. ESCA was easy because as a society, they had members that are both surgeons and also physical therapy and rehab. So from a professional society standpoint, it's easy. So when they approach us as a a society a few years ago, we say, okay, well, we need a partner. We need a North American partner to do this because, we need to have, our kind of rehab specialists to help us out. And that's why ASPT was invited to be part of this endeavor. But yeah, it's very, very, it's very enlightening to hear how care is being delivered in different parts of the world. Obviously, this is Europe and North American, but even within each country, there may be some variability. So that's why when we actually generate the statement, we're very cautious about not being so specific in terms of how it's being done, because it needs to be more generalizable. But it's very eye-opening. I think, Mark, maybe I'll actually ask your experience too. It's eye-opening for me to hear about what do you do for like a, if there's no initial treatment for surgery for degenerative tear at all. Basically, it's almost like say if a degenerative tear, everybody do PT first. Whereas in America, even though that with the evidence, there are some, patients still want to have surgery, but in Europe, it's almost accepted that you will not have surgery first, which is very eye-opening for us. Yeah.
Yeah. Do you remember those discussions, Mark? I do clearly
Oh,
remember some of them. Yeah.
Oh, for sure. I thought, I mean, and to kind of echo Dr. Ma too, I mean, it was eye-opening and to appreciate the variation in care, internationally as well. And I think, we can become very accustomed to how we practice in the United States or how we practice in our region, and having the opportunity to be on, many lengthy conversations with colleagues across the world, you get to appreciate the variation you see. And, again, we don't really know what best care is in many areas. So appreciating the strength of that variation and really seeing where we have consistencies, but also seeing where that variation may drive us to think differently about how we care for our patients was a great experience to be part of that. And I hope, and I think the manuscripts and the outcomes from it will be helpful, not just to give a general consensus of how we should practice or how we do practice now, but also give us ideas to how we can best move forward from there.
100% agree. 100%, Mark. Um, Dr. Ma, just briefly before we get into really kind of the meat of the article, can you describe just for everybody, maybe in a kind of briefly, how a consensus document like this is put together? I mean, what all is involved in it?
Yeah, great, Over. Thanks for kind of allowing me to go through it. And Philippe, before, as I mentioned his name too, he's kind of a guru. He actually really kind of was a champion of doing the consensus statement years ago. Yeah, you have an article that we always reference to, and he's kind of really the brain that can help us kind of get us to think about this, and actually lead the meeting also. So I think that it was really great, kind of working with him. Obviously, you start up with what the question is. The question is about rehabilitation, following meniscus injury. That's kind of like a question we want to answer a topic. Then we actually start to kind of go down like how to actually formulate the group. He's very, very formulaic in terms of how he does it. So you actually have kind of a what we call a four leaders that kind of help drive some of the processes. These are the four chairs. There's Nicholas Pujols, he's actually an orthopedic surgeon from France. Robert Pearl, who's a physical therapist from Europe. From the North America side is Ariel Giordano from your society. That's actually on the rehab side, and myself, from the orthopedic surgeon side from North America. These are the four chairs that really can help drive the process of getting them, getting the members engaged. Then it's actually very, very clear that there's a steering group, which is a group that actually picked to kind of really help guide the process. There are different phases, in terms of the consensus build. There's a literature phase, which is the one that actually we assign, members who go into literature and say, hey, let's look up topics on this, area, and generate, generate a summary of what has been done. Then actually we have a group that actually write the questions, because when you look at, I think part 2, I forgot this one, actually have 8 questions, right, or 9 questions. They actually write the questions about what the statements were,
Mm-hmm.
and then we actually have a what we call a rating phase. So the first part of it involves about almost like 30, Mark, correct me if I'm right, about 30 of 40 members actually were involved in the literature phase and the statement phase. Then we have a rating phase. Rating phase actually will open up to a larger audience, maybe I think about maybe 50 to 60 people. We ask these are experts. Hey, I give you this statement. I have that grading. Do you agree or not agree? And after that, they'll give us some feedback. And it's an iterative process, means that once we get a statement back, if they actually have good approval, great, then they actually finalize. If they're not, kind of have good approval, we need to ask and say, hey, what are the, questions that people have? Can we change the wording to make it, better until we get a complete consensus? So for the two articles that that was part of this consensus bill, I think that we talk about the part two, but part one and part two, we get 100% consensus for all the societies when we're done. So it's really an iterative process, and I learned a lot because this is kind of my second time doing consensus statement writing, and I would say the first time was not so organized. This is really organized and really kind of have a process go through. So it was fun. Mark, what's your experience? What's your experience? I think that ASPT have some consensus statement that in the past. What do you think about this process versus others you participated with?
Right,
Yeah.
right. I mean, this was very formalized process, which again, I think speaks to the rigor and which was behind getting us to a point of getting a consensus that was, again, acceptable to all that were involved, right? So again, I think, Dr. Ma mentioned there's a steering committee, there's a separate group that's examining the literature. Once statements were created, then we would send it out to raters, as Dr. Ma mentioned, and again, they would rate it on a 1 to 9 scale, and we needed to be in a certain range of consensus, or we had to go back and rework the statement. So again, it was very rigorous process, and again, I think again it speaks to we like to think we always have consensus, but that's never the case, right? So, but as close to a consensus as we can get to make sure we're making statements that all are agreeing on as current best practice for these conditions. So great. It was again great experience. So
Yeah, I
Can I
remember. I
jump
remember it
in real
being.
quick?
Yeah, yeah, of
Rob,
course,
would
Barb.
I jump in?
Yeah,
Is that
yeah,
okay? One of
yes.
the things I noticed, which you mentioned, Dr. Ma, that there was the evidence seeking stage, and then there's the consensus building stages and stuff, is that when you look at the outcomes of this, that a lot of it still, and this is, you'll probably talk about this as you get into the meat of this, but a lot of them ended up with grade D type evidence, which is essentially expert opinion, which to me shows how far apart we are still, even though we reach consensus, that we don't have a tremendous amount of evidentiary support for some of these things. Can you comment on that, like kind of how that feels, or to get through all this process and then say, you know what, we're down to expert opinion,
Mhm.
Yeah, great, point, and great, for you to kind of notice that too. Is that, but that's our field. I think the most important that we need to realize is that we don't have a lot of great evidence out there on what we're doing. That actually prompts us to, should we do a better job to study this over here?
Mhm.
So at least we could agree with the experts. Oh, this is what we agree things would be the right thing to do, but there's no evidence right now. So I think the fun thing about doing this is that how much we practice medicine right now on just, oh wow, it worked and we think it's going to work. I learned from so and so, I think it's going to work also. But I think that we as a field need to do a better job to do better science out there. Now there are some great ones that they have high ratings, which are clearly that's good evidence out there. But even when there's good evidence, sometimes when you look back at your own practice and say, oh wow, I didn't really did that over there. Maybe I should really change my practice because there's
Mhm.
clear evidence out there that I didn't even follow. Whereas like there's no evidence, I'm actually leading the field doing things also. So I think it points out some of the gaps we have in
Mhm.
our practices, and hopefully we make the field better because there's certainly a
Yeah,
lot of kind of room for improvement. Yeah.
No
I
doubt.
appreciate that. Thank you. That's great.
Yeah, it's great. Great question, Barb. So okay, so let's. We talked about it, just kind of the generalities about it. Let's actually get into it, and we can talk about initially. How about we talk about just prevention of meniscal injury and what we found in the results here. So Mark or Dr. Ma, either one, what do you think are some of the most the biggest or most important modifiable risk factors for meniscal injuries that we saw as we looked at developed this statement? What kind of things are modifiable that can be done?
I can kind of quickly speak, and then Dr. Ma, I'd love to hear your thoughts too. But so I mean, I think some of it's interesting because I was deeply involved in this portion of the consensus, and there's very little literature on prevention of meniscus tears. So really, we ended up leaning a lot on ACL prevention
ACL,
or
yeah.
just knee injury prevention to come to some guidance. So again, and to Barb's point before, there was a lot of expert consensus in this space because again, there was no evidence that said, hey, this prevention program will decrease meniscus injury specifically. But I do think, Rob, to your question, from a biomechanics or from a modifiable risk factors, I mean, certain things like, BMI, a lower extremity alignment are factors that, we know come into play when we think about the potential for injury. But there's also modifiable factors such as strength. Like we know folks who have, more sufficient strength in their lower extremity hopefully can control their movement patterns better and would be at lower risk for injury. And then there's other factors too, such as occupation or positioning that you'll get into with certain
Sport they
with
play.
sport
Yeah.
for sure. So I think those are some of the areas that are probably ripe for discussion about is there an opportunity to decrease risk or to prevent. But again, much of that section was really leaning on the ACL injury prevention. So
Yeah, I will echo that. But there's actually, have not much evidence out there, and most of us all know too that well, it'll be nice if we could predict who tears a meniscus, but we
mhm.
can't do it very well. It'll be nice over there. Uh, I do advise patients don't do silly things, right? I mean, that's number one. If you do silly things, probably, you risk of injury over there, but avoid the silly things. But a lot of times too is that, your muscle control, you're not, warm up well enough, or when you're tired, that's when actually your injury goes up. Most of it actually coming from literature ACL, but that's why the evidence is a bit low on this area. But there are other areas actually have much more better
Mhm.
evidence out there. Yeah.
Yeah. So Mark, like certain things to try to prevent, like neuromuscular training, and using some of the different ACL prevention protocols. Just like you said, I think it's the same thing. We have some evidence in ACL injury that there is evidence that maybe they help with ACL injury, but we don't really know in the meniscus, right?
Mhm. Yes. And could that be because we don't track that as closely as ACL
Hmm.
injuries? Potentially. But I do think, this is an area that was not all expert consensus. There was some low evidence recommendations. But again, the recommendations were, if you comply or if you participate in some type of injury risk or injury reduction education or injury reduction programs, you do have an opportunity to improve strength, improve neuromuscular control, and hopefully reduce risk. So,
Do either one of you, Mark or Dr. Mott, do you know how often, I'm sure I've probably seen this stat, but I don't have it memorized in my head. How often does someone tear their meniscus without tearing their ACL? Because it happens so commonly with people that tear their ACL, having the two injuries together. How often does it occur where you just tear the meniscus with not the ACL? And then my reasoning for asking that is because if the majority of them are torn with the ACL, you would think that a prevention program for the ACL would be somewhat preventative for the meniscus too, although there's again no proof.
Yeah, good question over there. I think it depends on, whether they are the acute meniscus tear versus more the atraumatic, chronic ones. Obviously, there are lots of degenerative meniscus tear right now that just get aggravated, with kind of minimal
Hmm.
trauma. So that's kind of like, having on the background. I think a lot of people age, 50 already, like myself, the meniscus is going to be injured. So those are the ones that, very, very prevalent. On the end, acute meniscus tear without ligament injury does happen. When you think about like the lateral meniscus tear, when the fascicle tears, we see a lot more right now with rock climbers, or people do a lot of extreme kind of twisting maneuver, or like medial meniscus tear, like the posterior horn when you have injuries over there, the ACL may be still intact. So I would not say that that's the majority. I would say that the majority of the meniscus injury, especially acute happen with some type of ligament pathology, but it does happen isolated. Also, I would not say that
Yeah,
actually
yeah.
completely, isolated group over there. Yeah.
Gotcha. Gotcha. What do we know about in regard to prevention? And maybe this is another one where we really don't know, but um, and Mark, this may be a good one for you. The like biomechanics or movement patterns So, for instance, if someone lands, well, if someone lands with too much flexion, too much rotation, too much valgus, um, it it seems theoretically that maybe that would increase the risk, but we really don't have data for that either, do we? Because do we know how much too much valgus is really, or too much rotation when someone is landing? Is there evidence to tell us what is clearly safe and what is not safe?
I think there's probably not as much of like a cut point or a cut angle. I do think generally we could say deep squatting, pivoting and twisting with compressive loads. Those are the positions or those are the stressors that we would be concerned with. I mean, I think, at contrary to maybe some of the ligamentous literature where we would say, this valgus position, we think that that's going to be the highest risk position for ACL injury. I've seen less literature related to that on meniscus injuries, more generally speaking, and definitely interested in Dr. Ma's thoughts as well. It's the deep flexion, it's the pivoting and twisting while in a compressed or a loaded position that I think we're most concerned of from a risk perspective.
Yeah, but I guess what I'm asking is there, yeah, do we have cutoff points for that? Because what
Yeah.
is deep? What is deep flexion? How much pivoting is too much pivoting? We don't know, do we? I mean, it's because
Where
people
of
do
that
those
literature?
activities.
No.
Yeah, people
Hmm.
do those activities and not tear their meniscus. So where's the tipping point when it actually gets torn?
Yeah.
Or do we know? We don't know, I guess.
Yeah,
Yeah.
good question, Rob. I would say no, I don't think we have any clear guidelines. And as you know, too, there's some people, if they are actually more hypermobile, they could flex more or they could
Yeah.
extend more and maybe okay, versus some people that actually maybe stiffer and then lower the joint a certain degree will be more problematic. And I'm gonna put my other cap on, put my little scientific cap on as a basic scientist, is that well, meniscus are different kind of mechanical strength as you get older, right? As we get older, you lose the amount of water content in meniscus. That's why it becomes stiffer. When it becomes stiffer, it tears more easily. If you repeat an injury to meniscus, you lose the water content. It becomes stiffer. That's why they could tear more easily. So that's why with the grade A evidence is that repetitive activity does increase risk. Hyper flexion on kneeling, which you increase load, that's put it more at risk, all related to the mechanical properties of meniscus. But older age have more meniscus tear because we lose our water contact also. So I think load, age, repeated exercises, those are the ones that put you more at risk. Yeah.
Gotcha. Gotcha. All right. So are we okay to move on to the next topic, which I think is kind of non-operative treatment? And so this probably is more for you, Dr. Ma. When do you feel like non-operative treatment would be preferred? So conservative treatment over surgery, according to the consensus.
Yeah, I think that, the second one to talk about rehabilitation for non-operative meniscus tear. I think that, it focus on, muscle, kind of control, build up strength. They also talk about things you want to avoid. Again, repetitive activities, kind of activities, high load activities are not good, when you have an acute meniscus tear. We didn't go into detail in terms of who should be treated non-operatively, but if we do non-operatively, what are things you should not avoid? I think that's what the focus of the statement is. Now, for me, when do I actually treat a acute meniscus tear non-operatively? Really depends on the activity level of the patient, also the symptoms. If the symptoms are not that high, or the activity level doesn't warrant a lot of kind of lower meniscus, we could try and treat them non-operatively, see how they do. Um, whether it's by the symptoms, what they respond, and also how you actually physically see the knee is responding. You see a lot of swelling in the knee, a lot of effusion doesn't go away even with a adequate non-operative treatment. Those are the ones you don't want to wait too long because clearly effusion means that something is breaking down, and that's actually would kind of push me more towards operative intervention, meaning that something's not right, something's still not responding, versus someone, oh, I saw a tear on the MRI, the physical examination is pretty benign, they're already back
Yeah,
doing
yeah,
things.
yeah.
You're more likely to say, hey, why do I need to treat that image, right? So I think that's what I tell people about it. Yeah.
How long do you, Dr. Mai, so you have someone that has an acute injury, and let's say they got in to see you relatively quick, so they get in to see you within a couple weeks, and you think that based on what they're telling you, you want to try conservative care. How long do you give the conservative care a shot before you decide that it's not working? Is it relatively quick? Do you give them plenty of time? I mean, it probably varies, but in general, what would you say your thought process is in regard to how much time?
Yeah. Yeah, great question. Obviously, depends on scenario, depends on the patient's kind of fitness and what their current state is. Now, a couple of weeks is not an early visit for me, okay, Rob? I don't want you to spread the rumor out there. It takes early, it's a couple of weeks to see me. So if I see them acutely, let's say a couple of days after the MRI of injuries over there, then I'll say I will probably give them 4 to 6 weeks in physical
Okay.
therapy, see how they do. But the caveat, which I tell people all the time, to that you gotta tell me if you don't feel good.
Yes.
Means that
Yeah.
if your knees start to hurt you more, swell more, or get locked up, I don't want you to wait 6 weeks before to come see me. So that's a caveat for me too. When I do non-operative treatment, you need to tell me how you responded to the treatment. If you actually, hey, let me do the physical exercises, and oh voila, my knee is even more swollen than before, or never swelling comes down. I'm still gimping, like a couple of weeks down the road. Um, Reach out to us, and we need to intervene earlier. I think that's the communication I have with my patients. Yeah.
Yeah. No, that's perfect. That's great. That's what I was wanting to know. Mark, so what would you say are some key components of um, high quality, non-operative conservative rehab for someone following acute um, injury to the meniscus?
Yep. Yeah, no, I think keys are, obviously rest management of the acute injury. So management of effusion, restoration of normal range of motion, and then activation of their quadricep for sure. So if they're having any deficits or inability to contract their quad, certainly that's an acute phase goal of ours: motion, effusion control, and obviously muscle activation. I think, and right in the line with what Dr. Ma was saying, really having a good discussion, understanding, and work, ability to work with your patient to say, how are these interventions influencing your symptoms, right? If you're starting to have locking, if you're starting to have a progression of their symptoms, obviously signs that we need to get them right back to Dr. Ma's office to make sure that we're on the same page with, the status of that patient. But if they continue to progress well and they have, resolution of their acute symptoms, effusions and control, normal motion, good quad activation, then working on progressing them through a more advanced rehabilitation progress to, again, advanced strength, and then ultimately working back towards what their goals are. So I think honestly that acute phase is really an important phase in our hands to understand how the patient is going to react to challenging them from a rehab perspective to see if their knee is progressing well or if we're just aggravating the knee more and it's not likely to be successful.
See how they tolerate it. Yeah, exactly. Um, Dr. Ma, we didn't mention that. Well, maybe we mentioned earlier, but we have question and answers or question. We have questions, and then we try to answer them from the audience. And we have a couple here. I apologize. I was just getting so into the discussion here, I wasn't paying attention to the questions. But we have a couple that we probably should have asked a little earlier. Paul Canavan asked, what about shoe surface interaction and cleat designs, like cleat and shoe, the stud morphology with knee injury? So I think he's asking, is there anything that you know of in the literature to support that maybe different shoes or different cleat design may decrease or increase the risk of someone having meniscal injury?
Yeah, Paul, great question over here. I think that, the most experience we have is actually with meniscus and ACL injuries with different shoe wear and surfaces. There are a lot of, information, a lot of, data being generated on, like, say, American football player, different kind of surfaces when they play, what's the incidence of ACL tear versus meniscus injury. Everybody kind of complain about the surface they actually play when they play against the New York Jets, because actually the surface actually causes a lot of injuries, and also it's a bad team, so maybe that's why people get hurt, but they play bad teams also. I hope there's no Jets fans out there. But that's actually primarily on the ACL literature. There's no direct on just meniscus alone, but you would think that the grip, the rotation, the more grip you have with the surface, the
Yeah.
more taut you got to go to the meniscus. Go back to what we actually have evidence is that, hey, if you do a lot of twisting maneuver, your risk goes up. So I think you would think that the higher load in terms of, twisting would actually increase your risk. That's what we kind of guess the relationship would be. But I'm not so familiar that actually a particular study really on that surface
Meniscus,
on surface of meniscus injury, but I may be kind of I'm not aware of it.
All right. Another question by Sarah Tyndall. And that's probably you mentioned briefly someone maybe having hypermobility and how that may play a role in tears or not. So her question is, to what point do we think hypermobility, I'm assuming she means in the knee, plays a role in tears or re-tears, especially postoperatively? So does hypermobility have a protective or problematic effect to meniscal tears? And she's asking especially postoperatively.
Yeah, great question, sir. I would say that that's something I don't have much information on, in terms of whether they actually have higher risk or lower risk in terms of re-tear the meniscus. There's some good data on ACL again, that hypermobile is a risk factor for re-tear, and some of them may have meniscus pathology also. I am not so aware that meniscus, outcomes of meniscus surgery have been looked at hypermobile or not. Maybe we should. We'll take a look at that. I would not think that they are protective if they have a tear, and they actually have it repaired. I think that they may tear a little bit less often than people that have stiffer joint. That I would kind of say that may be the case. I've kind of put my cap as a shoulder surgeon too, that people with hyperlaxia usually don't have a lot of labral pathology. They more have capsular pathology. But when you tear something, they may have a harder time to heal because they're so flexible. That's what I think it may be. But again, is actually level D. We don't have to do a consensus statement on this one. This I could tell you right off. It's like a level D kind of a grading over here, right, Bob? This is definitely like expert opinion.
That's right.
Yeah.
That's
I
right.
appreciate your expert opinion on that. I was curious too if you
Yeah.
thought that just with your meniscus repairs, if you have someone who has a hypermobility disorder, even something like Ehlers-Danlos syndrome, where obviously a difference in how they could lay down collagen, if you are either more conservative in the progression of their rehab, or if you're concerned with, hey, with the possibility of a failure of the meniscus repair.
Yeah, great question, Margaret. I don't, change my rehab in terms of the progression, in terms of the laxity status. I do kind of, hold them back a bit longer for return to sports. So, for example, hey, how long do you be on crutches? How long do you actually work on muscle control? How long do you work on kind of strengthening? And that is probably haven't changed in at least in my practice. But what I do advise them in terms of returns to sport, I'd hold them back because I do think that they're much slower to regain proprioception, because they're hyperlax. They need the proprioception more to control their activity. And the regular time frame, I don't think they could regain it so quickly. Now, obviously, if you test them, you're probably not going to regain. That's where you lengthen your recovery. But that's how you usually set them as a go ahead. Early on, I'll progress you very quickly, just like, regular recovery. But the last part, you may have a harder time to come back. So these people may come back in 6 months versus you may take longer, because you may be able to regain some of the control that other people are able to do so. Yeah, because I think people with hyperlaxity need that proprioception more than a stiffer joint person. Yeah.
Yeah, I agree. That's kind of the same. It's like you said, it's very similar in the shoulder too, Dr. Ma. I mean, if you're really hyperlax, you need a little more time usually. You don't try to rush it. So good. Jeff Wrigley asked, how does the fact that meniscal injuries are common in patients who are asymptomatic play into research in regard to prevention? So, or yeah, how do
Yeah.
I think just because a lot of people have, you mentioned that a lot of people that are older have degenerative meniscus tears, and they may not even know they have the tear. How does that affect treatment, I guess, and rehab and or prevention?
Yeah, that's a great question. And that's also something we kind of alluded early on to, is that our European colleagues are very, very adamant. Like for them, it's like the grade A, like almost like a Bible over there, that when you have an atraumatic meniscus tear on an older patient, everybody should go to PT first. They don't even get approved to do surgery in Europe unless you do physical therapy for atraumatic meniscus tear. which is different from North America. There are a lot of patients that comes in and I need to have a surgery done because my internist got an MRI on me and I have a meniscus tear. You have to almost talk them out of treatment. But I think some of them still undergo surgical treatment. But our European colleagues are very, very kind of adamant that should be treated with physical therapy first. In some country, they share with us is that they don't even get, surgery. It's not even offered as a treatment until they failed like 3 months of physical therapy. That was actually published in the previous consensus statement, and there's some help, kind of authorities in Europe actually have adopted that, kind of consensus statement as a practice they have. So I think most of us would try to be conservative with atraumatic degenerative meniscus tear because most of them are radiographic findings. They may not be that symptomatic, but even if they're symptomatic, they would do well with physical therapy or maybe injections. As we all know too, if we image anybody 55 and above, 50% of us will have a meniscus tear already inside the knee. I think Bob, myself, over there, is part of that. So
a lot of us on the call tonight, Dr. Ma, a lot of us are in that area.
So, I'll keep you a little lower, Rob. You're under 52 over there, so be okay. So yeah.
I wish. No, I like that. I like the discussion about load management. I was going to bring that before we get to more questions. I had a question about load management earlier, and it sounds like you agree. We got to be really careful of these people that have meniscal injuries when we try to either rehab them conservatively and certainly I think after surgery, really slowly adding load management to them like we do really any other musculoskeletal surgery. Mark, can you comment on that at all?
Oh, yeah. I mean, I think, when we talk about load management too, I think, especially with meniscus, I think we're thinking sometimes the load management conversation goes to how you transition back to activity, some of the classic acute versus chronic workload management. And I think with meniscus too, it's just, how much pounding do you put on that knee at any given point in time, right? And I think, again, we're considering the function of the meniscus is to obviously be a shock absorber in our knee. And so, controlling the load that we place on the knee throughout the rehabilitation process, whether it's non-operatively or post-operatively, is critical to ensure success and to make sure that, especially those we're talking about people over 55 who have decreased water content, probably have increased likelihood that they'll tear. We need to be cautious on how we progress those athletes through. So I think, both aspects of that, how, the acute load that we're placing on the knee at whatever phase of rehab we're in for that injury is critical for us to consider. But also, as people are transitioning back to sport or transitioning back to activity, how are we appropriately transitioning them back? Like just not saying, at the end of rehab, great job, go for it, and they go from 0 to 100 right away,
yeah.
right?
Yeah.
Like how do we appropriately transition them back to make sure that their knee can tolerate that function, that level of function?
Yeah, and you got to have some stop gaps. So if they don't, yeah, we can back them off and kind of restart from that point where they started having their problems. Exactly. Dr. Ma, Todd Lazenby asked a question about the lateral meniscus injuries, and do you think they are a little harder to recover from or rehab from due to the inherent mobility of the lateral meniscus and the inherent difference in joint surface between the lateral side of the joint and the medial side of the joint? So in essence, are lateral meniscus injuries or surgeries to you, do you worry about them a little bit more? Are they more difficult because of those aspects? Or are you concerned about them more?
Yeah, great question, Todd. As all of you know, that there is a difference in anatomy between the medial and lateral meniscus. The medial meniscus is, shaped like a C, more stable, tear more easily with atraumatic meniscus tear, but actually they're, more stable. Lateral meniscus have much more mobility, shaped like a O. Actually is a smaller volume compared to medial meniscus. And also, when you look at the blood supply, there's less vascularized on lateral meniscus. We all know that the meniscus get, blood supply from outside in from the peripheral through the capsule and come in. So outer third is the red zone, the middle part is red-white zone, the inner part is white zone. And depends on how much blood supply, the healing rate could differ. The lateral meniscus also have the same vasculature coming from outside in. The difference is that the lateral meniscus have the popliteus tendon that goes through. So the area what we call the popliteus hiatus, there's a tendon that goes through, and there's no blood supply around the area, which is the junction between the middle and the posterior third of the meniscus. That's the area that the popliteus come through, and that part of the meniscus is more avascularized compared to the rest of the meniscus. So that's something unique about the lateral meniscus that's different from the medial meniscus. It moves more, shapes more like O, and also areas that it doesn't have a lot of blood supply. So when you have a tear of the meniscus, with an acute ACL tear, you get a lateral meniscus tear. Most of those tears happen around that avascular zone. So you try your best to fix them. They may not heal as well. And there's also very good, evidence too. When you do a lateral meniscectomy, there's a different trajectory on the knee. They do tend to break down, very quickly with time. They tend to have less symptoms early on, but once it breaks down, the knee will go very quickly. So it's one of those kind of hidden injury. Oh, they feel great early on, but when you do a meniscectomy of those patients, they would break down quickly. You're gonna watch them because a year or two later on, actually the knee would become very arthritic. So things that we kind of can't ignore when we see that injury.
Great answers. Dr. Ma, do you do imaging on everybody that comes in with a suspected meniscus tear? Or are there certain people based on symptoms that you might forego imaging initially?
So obviously there may be a suspicion of meniscus injury with the positive clinical signs. I don't image everybody. Depends on like what kind of symptoms they have. Obviously if they're very symptomatic, I'm concerned about more than just a regular meniscus tear. I worry about like a root injury. I'll image them. There's certain things that would trigger me that I have to get an MR. Um, if they come in swollen, I almost have to do something to figure out how significant it is, because when it's swollen means that the cartilage breaking down, means that the injury is severe enough that something's going on. It could be a displacement meniscus tear, could be a root tear. Those are the ones that you don't want to kind of treat non-operatively right away, and you want to kind of at least see what the significance is. Or if they come in with a locked knee appearance, obviously the classic one are the bucket handles. They come in, you want to kind of make that diagnosis. Or your meniscus out of position, meaning there's a flap that move underneath itself, almost a tuck underneath, around the MCL. Those are very symptomatic. I do image them. But almost most patients, I would say almost all of them, if I take them to surgery, I would have MRI in hand. For me, I think when I see them initially, it's really about my suspicion, how my clinical suspicion about how severe they are. If they're severe, I think I'll get an image, see what the severity is. But if I actually have someone I know that need to go to surgery, I do need to get an image.
You'll do it.
Unless they have some limitation, they cannot get images beforehand. But almost everybody, I want to have some MR confirmation before I go to surgery, which is also something we found out different than some of our, our European colleagues. They actually would sometimes take patients to surgery without MRI diagnosis. If they have enough clinical suspicion, they would bring them to the OR without the MRI. Now, obviously, that's not everybody, but they actually are comfortable to do that. I think in their health system, sometimes it's more difficult to get an MRI before they go to surgery. So we actually met with a couple of colleagues, Mark, with part of this course, and you walk and say, hey, not everybody needs it. Now, North America, everybody gets it. But in some countries, no, they have enough clinical suspicion to go right into surgery without getting MRI. But still, it is a smaller subset, but it certainly can happen, yeah.
Yeah, good. You mentioned a locked knee, and we have a question from Polo Edwards. Polo, thanks for joining. She is one of our, if I remember right, I think she's one of our former Sports Academy traveling fellows. Her question is, she's asking a question about meniscal tears during pregnancy. How often do you do surgery on someone during pregnancy? So for someone who has like a meniscus tear with a locked knee, where they can't move it, do you do surgery on them? What What kind of nuances are there with that type of a patient?
You're asking me all the tough questions here,
Yeah,
Polo, over
yeah,
here.
there's
So
some good ones.
uh, that's good. That's great over there. So has that happened before? The answer is yes. And I think that obviously it depends on the stage of the pregnancy,
Hmm.
about where they at. Because there are certain stages that having anesthesia will have significant effect on the baby versus later stage. I've done surgeries on people early stage of career, early stage of pregnancy, before 16 weeks. Basically, we have the obviously our anesthesiologist talk with them with OB to the hey, there is a likelihood that this will put too much stress on the fetus. The fetus may not do well, and at that time it's not a viable fetus. So I think that they don't have to have OB backup. So when I do surgery on patient that's 16 week, usually 16, 18-week pregnancy or lower, I don't have to do it in the presence of an obstetrician because at that time the fetus is not viable. The good thing about anesthesia colleagues right now, they have a lot of anesthesia, a lot safer right now in terms of, for the actual surgery itself. So when you come in with a lock knee at like say 14 weeks, we actually would do surgery on them without any concerns at all, knowing that there is a risk to the fetus, but the risk is not so high. When you're actually in the second, trimester or third trimester, it gets a little bit, more difficult. Means that the fetus is viable. So if anything happens because of the manipulation or maybe the surgery itself, they need to be done at a site that actually there are obstetricians around to help out. So I've done surgery at the Children's and Women's Hospital. Sometimes a lot usually may be related with the ACL. So I have done ACL on people further along. That actually have them back up, so that allow them to be able to respond if the baby is not doing well. Fortunately, that has not happened in terms of the baby, but still, that that's having a OB backup is extremely important. The other thing
Yeah.
scenario is that are there cases that you should not operate on the middle? Just wait it out. You have a lock knee, but life's tough. Lock knee, or make it lock for another few more weeks before the baby comes. I certainly could, kind of imagine scenario like that. I had patients with loose body before that had the knee really, really uncomfortable at the really end, at tail end of the pregnancy, and as well, we could do it, or can you toughen it up and see how you do? In that particular scenario, she's able to kind of go through pregnancy, and we do surgery a week later after the baby is born. So I have a few scenarios, but they're really individualized. But obviously, a frank discussion about the risk and the benefit, I think, is extremely important. Yeah.
Yeah, good. I wasn't expecting that. That's good. Good to know, though. So we're almost done. What I'd like to ask just you a couple questions real quick, Dr. Ma, about return to sport following meniscal injuries. So what if you have a patient and let's say you did meniscal surgery on them and they're trying to get back to playing, whatever basketball, whatever sport they're playing. What criteria or what are the major criteria that you want to see for that patient before they're allowed to actually go back kind of on their own, with the team, participating, practicing, things like that?
No, great question over there. Obviously, we want them need to be responding well for treatment, means that there's no effusion, strength is returned. You can actually make them do some agility testing to see, how well they are in terms of performing that. Make sure that, the control is there in terms of single leg hop, and actually, and single leg squat, and make sure they actually don't have a lot of bowel substitution. So those are the criteria. And I work very closely with the physical therapist, and if they actually have a sports team with an athletic trainer, I work very closely with them. How they move on the court over there? Are they, when they're in practice, are they able to push, kind of, well and off that knee? Are they going to still having issues after practice that the knee swells? If it is, I don't let them go back to competitive sports over there. So it depends on the level that they are. I feel more comfortable when I actually have more eyes watching them to kind of let them
Mm-hmm.
do it. So
Yeah.
for people actually in, like, say that my college or more professional, the more eyes on them, I'm more likely to let them go back a bit earlier because I know that someone's going to watch him. As you know, if I see a patient at the 4-month mark with a meniscus surgery, oh, I'm doing great. I'm doing great. Can I go back to tennis? The minute you say yes, they'll go do it, and they won't
Mhm.
see you until their knee completely, got the trash or swollen. So, then less eyes looking at them and say, no, let's wait a little bit longer. I'll see you back in 6 months, see where you are, hold you back a little bit longer. That's why usually my approach to my patient. Again, what are your support system for you and also a support system for the patient? I think it's really important to kind of assess that. Yeah.
Is there any mistakes that you think we make? I say we collectively, that one includes, I guess, you surgeons and therapists or athletic trainers. Is like the biggest mistake, do you think, maybe just allowing someone to go back too soon, or maybe not doing enough tests to determine really if they're ready or not? I know that happens. I mean, um, people maybe are seeing therapists that aren't sure what tests to do, so they do just a couple tests and let them go back, and maybe they're not ready. Are there other mistakes that we need to be cautious about, other than allowing too soon and maybe not testing enough?
Yeah, I think that's obviously the big one over there.
Yeah.
And the other thing too, that I would say that sometimes we may not listen as well to our patients, because sometimes, oh, this is your 3 month mark. You had a mastectomy, you're doing great. Oh yeah, you could do this, you do this, that's great. Do everything I want over there. Sometimes we may not pay attention or listen to them as much because remember our encounter with them is very short,
Hmm.
right? It's only at a moment in time. Also, we never really see them, play tennis. We never see them when they do activity. We see them when they come in the clinic, which may be 8 o'clock in the morning. They just woke up from bed. The knee's going to be really calm over there. So sometimes we don't listen as much over there, and I actually a huge culprit on that. Also, I have a busy practice. I don't listen to my patients much, but I think that's something that we say that we as a field could we do a better job? Could we listen to our patient more? Because they sometimes would tell you that, hey, something's not right.
Yeah.
Something's not good. I need to be looked at more closely. Be available, because sometimes, they may not come back to see you at the office, but if you give them the ability to, hey, can you email me through the MyChat portal? I mean, draw me a note somewhere. Just give me a text in 3 months, see where you are. Um, Having the ability for them to reach out to you, I think is extremely important because that would kind of hopefully avoid a lot of the most severe injuries because sometimes we let people go back too early but we also don't follow up with them as closely as we should be. I think that's something we could do better. Yeah.
I really appreciate your honesty about that, because I think and I don't think you're alone. I think we all, especially
Mm.
like you said, if you're busy, sometimes things get by or you don't hear, or maybe you didn't ask the right question because things were moving fast, and it happens to more people obviously than just you. So, but I appreciate your honesty about that. All right, we've been, believe it or not, Dr. Ma, this always seems like it's been about 20 minutes, but
Oh,
it's been an entire hour already of all of this conversation. So this was great. We definitely, we would love to have you back. There's
For
like a
sure.
ton of questions we didn't even get to.
Hmm.
Um, so
Yeah.
if in the future you'd be willing, we'd love to have you back sometime, and we can get some other topics, or we could even just stay with the meniscus topic. I know this is a great one that people love.
Hmm.
Good
no,
call on picking one paper, Rob.
I know,
Yeah,
I know.
exactly.
16
No kidding.
questions in the
Yeah,
queue.
yeah. The way that haven't been answered. Yeah.
Yeah.
Hmm.
well, I'm happy to
More.
help. Obviously, I'm honored to be part of this over there. Apologize, I didn't go through all the questions. If you want to send the question
Oh
to
no.
me, Robert,
Oh, no, no, no.
send to
It's
me.
okay.
I'll
Yeah.
happily answer them. I'll mail to you guys also. But
No, we'd much
it's
rather have
fun
you
for me
back
to
on
do it.
again. Yeah. We'd
Yeah,
much rather have
love
you
to be
back on
part of
again
this. Yeah.
later. Yeah.
Well,
Yeah,
Dr. Ma, at the end of these, our title sponsor, ATI, is a physical therapy company, and their research group at Manske. We have a guest speaker that does a little, we call it case in point. So it's basically some case examples related to the topic. So Enrique is our guest tonight. Enrique, I'll let you unmute, introduce yourself, tell us who you are, where you're at with ATI. And you should be able to share your screen and jump in. And we'll quickly go through that and see if there's any questions at the end.
Yeah, sounds good. So, yeah, my name's Enrique Claudio. I'm a physical therapist with ATI. I'm currently halfway through orthopedic residency with ATI. I've been practicing for 2 years, graduated from Springfield College in Western Mass. And yeah, and I put together just one patient quick clinical case. Should take like 10, 15 minutes to go through, but um, that's the intro for me. I'll try to share my screen here. Let's see. Share. Can you guys see the PowerPoint here?
Not quite yet. It just says double click. Oh,
There it
now
is.
there
Yep.
we go. Now you
Okay.
just have to go into presenter mode and we're good.
Yeah. Beautiful. Present. Okay. All right. So here we go. Yeah. So this is just a case on a non-operative meniscus rehab case. So we'll get into it. This patient was a 28-year-old female. Status post a motor vehicle collision with a suspected medial meniscus pathology. So previous medical history, she went to the emergency room on January 14th. She reported that she was sideswiped on the driver's side on the freeway. And then she presents to physical therapy about 3 weeks later on February 2nd is when she came in to see me. This was just a quick systems review in the hospital. Everything was clear. Besides musculoskeletal was her primary complaint of right knee pain and left wrist pain. She denies any imaging in the hospital, no radiographs or MRIs. The right knee pain was her primary complaint, and she reported 8 out of 10 pain at baseline, at rest in the hospital. Aggravating factors, prolonged standing and sitting for more than 30 to 45 minutes is what she told me on eval. Squatting, stairs, lunging, anything with deep knee flexion was aggravating. And then she did say she had some ease of the pain with rest. So here's her objective exam on the day of evaluation. So knee flexion, active, range of motion. She could get to 92 degrees, passively 95 degrees. She reports both were painful. The 95 degrees was empty end feel. She was guarded and she wouldn't let me take the knee any further. Extension was normal and not painful. Strength testing for the quad and the hamstring. She had good strength. She reported both were painful. I think at that point in time, it wasn't necessarily the resisted testing that was painful. I think just everything, the whole experience was painful in terms of the amount of effusion she had in the knee. She had moderate swelling with a sweep test, and then she was tender on the medial joint line and 90 degrees of flexion. She came in with an antalgic gait from like the waiting room to the evaluation room. She had a pretty good limp on the right leg. Standing posture, she stood with the right lower extremity hyperextended and kind of propped her heel on the floor to offload that right leg. Special tests, ligamentous tests, were all negative. One of my biggest concerns was PCL injury, just based on the mechanism of injury. But that was cleared. She did have a positive McMurray's and Thessaly's on the right side and the right knee. Functional assessment, she had pain with a deep squat at about 90 degrees. She offloaded her weight, shifted to the left. She had increased pain with single leg stance on the right side. And her knee outcome score was significant for moderate disability in the knee. So differential diagnosis, just kind of what was going through my head as I was doing the evaluation. My first was meniscus pathology, just based on her objective findings and subjective reports. The second concern was for me PCL injury, but that was ruled out with special tests. The other was kind of like anterior knee pain, patellofemoral pain syndrome, just based on her aggravating factors, deep flexion, stairs, squatting. So could be patellofemoral pain syndrome. And then the biggest was fibular fracture, patellar fracture, which was going through my head as she came in. But as soon as I saw her kind of walk and weight bear those 4 steps, that was ruled out with the knee Ottawa rules. So rehab overview. The big thing, I broke it down into 4 phases. Right now, we're kind of in phase 3 with this patient. But the first was to reduce the swelling and inflammation. So we know there was a lot of patient education on just protecting the knee, Optimal loading is the OL there in that acronym. So I told her like weight bear to what you can tolerate. Be careful with what you do if anything aggravates your knee. Um, and you have any increased swelling, just try to sit, take a break, and then ice compression and elevation to get the swelling down. Phase two was just to restore her flexion range of motion and to reduce any quad or hip atrophy with the knee and try to prevent any arthrogenic like inhibition due to the swelling. And then phase three would be a 30-day progress note and reevaluation. And then phase four is soon to be coming, but return to her prior level of function. This patient is an avid runner and does participate in some like independent workouts in HIIT classes. So this is what it looked like for phase one, phase two. So I did some manual lymphatic drainage, some cryotherapy to get the effusion down. We focused a lot on just some light quad activation exercises. With intermittent manual therapy, she did have relief with Mulligan mobilization at 90 degrees. So that just helped her tolerate some of the exercises. And then my big like criteria for progression from phase one to phase two is just to reduce the edema and try to reduce her symptoms, the irritability of the knee. So this is 30-day progress note, reassessment at 4 weeks. Her pain did decrease significantly, especially at its worst with movement. Range of motion improved. She no longer had pain with active range of motion. Passively, I could get her to 130 degrees and still a little guarded and empty end feel. I did feel like I could push her to 135, 140, but I don't think she would have loved me that day if I did that. But good improvements in range of motion. No more significant swelling, negative sweep tests, and her outcome score for her knee improved pretty significantly to minimal disability at 4 weeks. So that was a huge plus. So this is kind of where we're at now in her rehab phase three. So the big goals for her now in rehab are some closed chain strengthening versus a lot of the open chain stuff that we were doing initially. So recently we did start working on some proprioceptive type exercises and some more like true loading of the quad and the glutes on the leg press. I'm not having her go down to 90 degrees just because it's still irritable. So we're doing about 75 to 80. Um, and then in here, I just put what I'm looking for criteria for progression to move to phase four. Um, Similar to ACL rehab progression criteria as we move into like return to full activity and plyometric type movements. So a good wide balance test score, leg symmetry index for the quad within 70 to 80%, no swelling, full range of motion ideally, and looking at single leg hop test and crossover hop test within 85 to 90%. And then, so we haven't gotten to phase four in her rehab, but the goal would be to return to jogging, plyometric training, and to kind of increase her quad exercises and her whole strength and conditioning program to more traditional strength and conditioning principles at like 65 to 70% of her one rep max for muscle hypertrophy. And then some motor control exercises. I did talk to her at her progress note a little bit about like what happens if we get to phase four and your knee starts to aggravate you again and swell up when we start running. Like, would you be opposed to see an orthopedic doctor to go over your options and potentially surgery if that's what you need to do? She was suggested to go get an MRI done, but she didn't follow up and declined to get the MRI. And based on how she was doing in therapy, she was okay with that, but we did have that discussion on if you run and this knee swells up again and your pain increases, what's the next step? Are you open to that? Right now, I would say she's not open to any surgical intervention, but in here, this is just a study I put in here for this presentation based on, I was curious myself on effective early surgery versus PT on knee function with non-obstructive meniscal tears. This had a good follow-up at 24 months, so 2-year follow-up, and both PT and surgery had similar improvement. in outcomes on the IKDC. So I found that interesting. I had read these two consensus studies actually like 2 weeks before I was asked to do this. So after reading the consensus too, um, it answered a lot of my questions that I had. The consensus had a lot of questions that go through my head a lot as I'm going through non-operative meniscus rehab. So my key discussion questions were, what is the key criteria for transitioning between phases in non-operative rehab? After reading the consensus, I realized there's not a lot of high quality evidence out there answering this question. But I think reading the consensus just kind of made me feel better about what I was doing in clinic. What would the key timeline be and indicators be for someone undergoing non-operative treatment to indicate that surgery might be necessary? And then what matters more in operative versus non-operative decision making, age or pre-morbid status, and how does that play a role on returning to previous functional status? Um, and then that's my clinical case. So a lot of these questions were talked about on this call today, so that was helpful. But
Great. Thank you so much.
yeah.
Any questions from the panel for Enrique?
Maybe
You
I'll share
nailed it,
some,
bud.
experience on this over here. Enrique, you asked about when, this patient should be, seen for surgical consultation. I think, as you said too, is when she starts to swell,
Hmm.
or, symptoms return. I think that's probably appropriate.
Okay.
And there's actually, just to share with the group too, when we were coming up with the consensus, we were grading the the treatment for non-operative treatment for traumatic meniscus tear. It was actually lower evidence at the time until this article came out, which is actually the DREAM trial
Hmm.
that was actually published in JOSPT, which is look at early surgery versus physical therapy for people with traumatic and non-traumatic meniscus tear. It's actually a randomized level 1 study. They really sway the evidence, of non-operative treatment for acute traumatic meniscus injury. In that particular study, they actually look at physical therapy for people with traumatic and meniscus tear and could still yield very good results. So not everybody needs to do surgery right away, even though that in North America you cannot walk out of a surgeon's office without having a surgical appointment booked. But this study over there actually look at non-operative treatment and people still do pretty well. But yeah, I would say that is follow the patient, see how they do, and if they continue to do well, obviously you could avoid a surgical consultation. But great job on this. Yeah.
Thank you. Can I ask you a quick question?
Yeah.
Is there anything out there in terms of like if this patient goes not conservative route and ends up having a good outcome, which right now it seems like she will, is there anything out there on terms of like what is her risk for developing like early onset knee OA if she doesn't have this operatively taken care of versus this non-operative route?
Yeah, good question over there. Depends on what the meniscus pathology is. If it's a root tear, the
Mm,
data is very clear right now. You do non-operative treatment of a root tear versus operative. There's a significant difference in terms of the development of osteoarthritis down the road, and also a need for a replacement.
okay.
We have a complete root tear non-operative. 50% people may get a replacement in the next 2 to 4 years or so. Now, if it's a atraumatic meniscus tear or non-displaced meniscus tear, there's no great data on that because sometimes when we do the surgery, we may not be repairing these meniscus. We may be taking the meniscus out. So the literature is a little bit mixed about if you go and do surgically remove the meniscus, they may be less symptomatic, but they may be more active. They're actually degenerate the knee more versus, hey, they have a small tear, they may not be as aggressive, their exercise more curtailed, they may last a little bit longer. So the literature is very mixed about, hey, does surgery really increase the risk of these, tears, or maybe non-operative do well also. But there's no, great data. to look at that.
Okay.
I don't know, Mark, Robert, you guys familiar with anything over there, but if they're asymptomatic, there's absolutely no reason to do surgery. So I think that they're doing well. That should not be a part of the decision tree to do treatment. Yeah.
Thank you.
Awesome. Well, thank you so much. And thank you to all almost 400 of you, 360 plus people that stayed on.
Yeah.
All the way to
Awesome.
the very bitter end. We will be back again next month. Topic to be determined, but we will be back as always. And Phil texted me and said, "Tell everyone I said goodnight." He had to jump off for a different obligation, but thank you all for joining us. Thank you, Dr. Ma, for being here. Enrique, Mark.
Yes, thank you.
Thank you so much. And yeah, everyone have a great night, and we'll see you next month.
Thanks, everybody.
Thank you guys.
Bye.
Thank you, everybody.